Hi everyone, my name is Rima Tawfiq and I'm a first-year hematology oncology fellow at Mayo Clinic in Jacksonville, Florida. And today I'm going to discuss with you our study looking at cardiovascular morbidity in Erdheim-Chester's disease patients with and without cardiac involvement. Erdheim-Chester's disease, abbreviated ECD, is a rare non-Langerhans cell histiocytosis with approximately 80% of cases having clonal alterations and genes encoding components of the MAPK signaling pathway. Most are BRAF V600E mutated. And typical manifestations of ECD include diabetes insipidus, sclerotic bone lesions, restrictive pericarditis, and perinephric fibrosis. Approximately 40% of cases have cardiovascular involvement of ECD. However, our understanding of the characteristics of cardiac-involved ECD and how this affects outcomes in pre-existing diseases remains limited. We aimed to determine the association, burden, and severity of pre-existing and de novo cardiovascular comorbidities with ECD-CV compared to patients without cardiac-involved ECD, abbreviated ECD-no-CV. We did so by looking at records of patients with ECD diagnosed from January 1990 to December 2021, seen near Mayo Clinic in all three sites, including Arizona, Florida, and Minnesota. Cardiovascular involvement was diagnosed based off of imaging, and cardiovascular comorbidities were captured both before and after ECD diagnosis. Cardiovascular comorbidities were graded based off the CTCAE version 3 grading system, with mild considered grade 1, moderate grade 2, severe grade 3, and life-threatening or disabling grade 4. Cumulative CV disease burden was defined after considering 8 cardiovascular comorbidities known to have structural and functional implications on the heart. These include hypertension, coronary artery disease, myocardial infarction, congestive heart failure, atrial fibrillation, pericardial effusion, valvular disease, and conduction disorders. A composite CV morbidity grade was assigned based on the highest grade assigned and one of the 8 CV comorbidities. Chi-square test and multivariate analysis was used to analyze the study. We identified 106 ECD patients, and among those, 38% had cardiac involvement. The median age at diagnosis for the entire cohort was 58 years, with a range of 48 to 67, and 61% were males. Table 1 outlines characteristics of the study population, including the mutation status, organ involvement, and further cardiovascular comorbidities. In this cohort, we found that patients with cardiac-involved ECD, they had an increased prevalence of pre-existing hypertension and myocardial infarction compared to patients without cardiac-involved ECD. Additionally, de novo diagnosis of hyperlipidemia and congestive heart failure was seen more frequently in ECD cardiac-involved patients compared to patients without cardiac-involved ECD. However, there was no significant change in the severity of pre-existing conditions in patients with and without cardiac-involved ECD. Table 2 outlines the cardiovascular comorbidity burden and severity in patients with cardiac-involved ECD compared to patients without cardiac-involved ECD. And what I'd like to highlight is that patients with cardiac-involved ECD had a greater cumulative cardiovascular disease burden, both before and after ECD diagnosis. Furthermore, patients with cardiac-involved ECD had a greater severity of cardiovascular morbidity as defined by a composite grade greater than or equal to 4 than patients without cardiac-involved ECD, both before and after ECD diagnosis. After considering BRAF V600E mutation, age greater than or equal to 60, smoking, ECD cardiac involvement, and first-line therapy, conventional versus targeted therapy, ECD cardiovascular involvement was the only factor independently associated with a composite grade of greater than or equal to 4, both before and after ECD diagnosis. However, I would like to make note that in patients with cardiac-involved ECD, a composite grade of greater than or equal to 4 before and after ECD diagnosis was most attributed to pericardial effusions, about 42%, and coronary disease, about 50% before and about 41% after ECD diagnosis. Therefore, in conclusion, cardiac involvement by ECD did not prognosticate patients. It did not worsen the pre-existing cardiovascular conditions compared to patients without cardiac-involved ECD. However, patients with cardiac-involved ECD had a higher cumulative cardiovascular disease burden and a higher grade of pre-existing and de novo cardiovascular morbidities compared to patients without cardiac-involved ECD. And the presence of cardiac involvement in ECD patients was independently associated with a severe cumulative CV disease burden grade. Thank you all for listening to my presentation. Please don't hesitate to reach out to me if you have any additional questions.